Hello, welcome to FISPGHAN Expert Insights. I am Songpon Getsuwan from Ramatipati Hospital in Bangkok, Thailand. And today I'm with Professor Nedim Hadzic from King's College Hospital. Hello, Professor.
Hello, good afternoon.
So today we're going to talk about the recent FISPGHAN position papers on the infantile cholestatic jaundice. So with genetic etiologies now identified in a substantial proportion of cases, could you please tell us about the roles of genetic testing in infantile cholestatic jaundice?
Certainly, thank you very much for inviting me to join you today. Just to comment on the review paper which we produced some months ago in JPGN. So the real question is really how we reflect the certain developments in the genetics in medicine, and how is that applicable for pediatric hepatology, and particularly into investigations of prolonged neonatal cholestasis. And we are all very excited with all these developments for the last 5 years, and certainly we think that genetics has started to play a very significant role in that area, particularly for the cases, for the situations where we do not really have anatomical explanation. And particularly relevant for us is that the proportion of the so-called unexplained idiopathic neonatal cholestasis, which we used to term very vaguely idiopathic neonatal hepatitis or something, or cryptogenic cholestasis, or something not really very specific. So this proportion of the patients has become significantly to shrink down. So we are talking about probably that maybe 10 years ago we were talking about 50% of unexplained causes of infantile cholestasis. Now we are probably down to something like 15 to 20% of unexplained cholestasis. And this is certainly the contribution of the introduction of genetic methods in our diagnostic options. So very welcome to see that, certainly improvement in putting more specific labels to certain conditions, and definitely improving diagnosis not only of liver conditions, but also some metabolic and other conditions which could come disguised as neonatal cholestasis.
So thank you, Professor. So in terms of the resource variable settings, which clinical scenarios should most strongly trigger prioritizations for genetic testing?
The first option really, or first job for a liver doctor in this particular setting, is to try to rule out anatomical causes of infantile cholestasis, particularly a condition called biliary atresia. And then once we have achieved that, there are no genetic tests for biliary atresia, there are no really fanciful methods to diagnose biliary atresia, so it's down to good old-fashioned clinical judgment. And then if we have excluded that, then we try to look into other different reasons why someone could have this prolonged neonatal cholestasis. So my view is that we are not talking about genetics as a first-line investigation, but certainly if the child continues to have cholestatic features into 2 months, 3 months of age, then we would consider genetic tests. It's, I think, at this point relevant to mention that historically we have been doing more liver biopsies than we are doing now. But now it appears that genetic tests are slowly squeezing out the liver biopsy because of the perception of relative invasiveness from the investigations. And that may be the trend which probably will only increase in the years to come. The only downside of these genetic tests is, of course, that the turnaround of the tests, the time required for the results to come back often is really several months rather than days or weeks. And that at the moment is a little bit of obstacle in this kind of clinical scenarios where the people plan or wish to get the diagnosis very soon or as soon as possible. So my guidance for genetic tests would, if we cannot afford to do them in all of these patients, would be definitely to try to prioritize the ones where there is a family history of similar infantile cholestasis in the past, conditions that come with the elevated bilirubin but low gamma GT serum levels. And also, if the workup had included measurement of serum bile acids, then the serum bile acids elevation would also be a very significant pointer in direction of trying to find a genetic cause of prolonged infantile cholestasis.
Well, thank you, Professor. For those of you who are looking for more information, the recent FISPGHAN position papers on infantile cholestatic jaundice has provided details for this topic. So thank you everyone for watching, and please refer to the following link for the position papers. Thank you and goodbye.